Excellent session. Thanks a lot.
Thank you everyone for your wonderful insight. That was quite an interactive session. Moving on to our next session, which is refining artificial ventilation. We call upon to moderate Dr. Bhuvana Krishna. She is the head of department, critical care medicine, St. John's Hospital, and Dr. Pratibha GA, associate consultant at Manipal Hospital, Yashwantpur. To chair the session, we have Dr. Swapna Kanzode, consultant physician and intensivist at Nagpur Hospital. Dr. Deepak T.S., Professor and Head of Department, Critical Care Medicine, MS Ramaya Hospital. Dr. Venkatraman Kolar, Clinical Director, Yashoda Hospital, Hyderabad. Dr. Murlidhar T.R., Head of Department, Critical Care and ICU, Kaveri Hospital. And Dr. Madhusudan K., Associate Consultant at Apollo Hospital. Over to you.
A very good morning. We've had a wonderful first session and very good discussions. So without much ado, I'll go on to the next session for today, refining artificial ventilation. I call upon again Dr. J.V. Peter to take us through new insights to PEEP titration. Over to you, sir.
First of all, I must thank the organizers for giving me this topic. Quite a challenging topic to go through and assimilate a lot of the things that have happened recently. I'll start with an introduction, moving on to what are the goals in optimizing PEEP, what are the methods, particularly the newer methods of optimizing PEEP, and then what do we do at the bedside despite all that new things that have come, and then conclude. The definition of ARDS has evolved over time, and these definitions have facilitated epidemiological studies. It has helped us understand pathogenesis, identify subtypes, and assess treatment modalities and outcomes. I think it's important here to emphasize that there are many causes of ARDS, and there are several mimics. And there is considerable heterogeneity in the way we look at ARDS, but the treatment has generally been quite homogeneous. All the good supportive care and improved ventilatory strategies have improved outcomes, mortality still remains high. There are several ventilatory strategies that have been evaluated in ARDS, much of which will be talked about during this session. And what has been given to me to speak on is optimal PEEP. Now, what are the goals of optimizing PEEP? If you ask me, once I optimize PEEP, I should have the best PaO2 and oxygen delivery, have the lowest shunt and dead space, have the best perfusion, have the highest compliance that I can achieve. The PV curve should go from convex to concave. It should have the best aeration on CT, and all these should be achieved with a plateau pressure of less than 30 and a driving pressure of less than 14. So is there an optimal method of titrating PEEP that will enable these endpoints? I think no. There is no such thing as an optimal PEEP. We are being too idealistic. And there is no optimal method, at least as far as we know based on science now, for determining this mythical PEEP. What could be a more realistic goal is to achieve open lung ventilation by maximizing oxygenation, minimizing end expiratory atelectasis, that is maximizing end expiratory recruitment, and minimizing end inspiratory overdistension. So it's a balance of overdistension and atelectasis. Now, why do I say there are challenges to finding an optimal PEEP? Because as I said earlier, the pathophysiology of ARDS is very, very heterogeneous. We have the pulmonary and extrapulmonary forms. And within a particular patient itself, there is so much of heterogeneity. Part of the lung is involved, other parts are not involved. It also depends as to which stage of the illness we are looking at, whether we are looking at the early phase or the later phase. And now there is so much of talk about phenotypes, subphenotypes, the L type, H type, F type, and all these will influence how we optimize PEEP in these subset of patients. And apart from this, there is dynamicity. Everything is going to change when the patient is right side up or left side up or prone or flat. And over time, there are changes. So the question to ask is, what is the primary goal in optimizing PEEP? Do I want to improve oxygenation by optimizing PEEP? Or do I want to limit lung injury? Or do I want to have both done? So what are the trade-offs? There is overdistension if you give too much PEEP. There is ventilator-induced lung injury, RV dysfunction, hemodynamic abnormalities. And if I underdo it, there is derecruitment, hypoxemia. Again, you can perpetuate ventilator-induced lung injury. Now, this is a very nice article that was published last year, which exemplifies the heterogeneous nature of ARDS. The one on the right side has extensive gravity-dependent consolidation, and there is a potential for recruitment. The one on the left side is more ground glassing, limited consolidation, less chance for recruitment. So between two types of ARDS, there is heterogeneity, and within the same patient, there is heterogeneity. Now, what do the experts say on PEEP titration? The European Society of Intensive Care Medicine published this paper in 2023, and they looked at these two aspects, higher versus lower PEEP FiO2 strategy and respiratory mechanics versus PEEP FiO2 strategy. And both these, they have no recommendations to make. So what do? The ESICM recommendations are undoubtedly sound from a methodological perspective, but leave the clinicians at the bedside in dire straits. So do you say, I give up, I don't know what is there, we'll just arbitrarily do something? Or at the bedside, do we try and set a PEEP to a reasonable point? So there are complex tools as well as there is a practical approach, and we look at these. Broadly, there are a few more also available, but these are the main methods for PEEP titration, the traditional PEEP FiO2 table, titrating PEEP based on respiratory and lung mechanics, titrating based on imaging modalities, transpulmonary pressure based, and electrical impedance tomography. For most patients, the ARDS-NET PEEP strategy is reasonable. It's based on the table. And here, the strategy is to target oxygenation. And there is no superiority of high versus low PEEP. There are 3 trials that have looked at this. But in a subset of severe ARDS patients or patients with chest wall compliance problems, you may need to individually titrate, and you may need to use more sophisticated methods of PEEP titration. So here, the target is oxygenation. Moving on to PEEP titrate to respiratory mechanics. You're not looking primarily as oxygenation as the endpoint of titration. You're looking at respiratory mechanics in terms of getting the best static compliance. And this can be done by looking at the highest static compliance at different PEEP, and then you can look at the recruitment potential. Now, the PEEP is increased in steps of 2, and the highest static compliance is considered the best PEEP. In a trial that recruited 70 patients which compared individual PEEP setting based on compliance versus the FiO2 guided therapy. So here you're looking at compliance based or static compliance based PEEP titration versus oxygenation based PEEP titration. This authors found there was less organ dysfunction with the static compliance based PEEP titration methods, and there was a trend to mortality. Reduce mortality. So this prompted this large ART trial, which was published in JAMA, which looked at 501 patients enrolled into best respiratory system compliance versus low PEEP strategy. But this trial found that the titration based on mechanics had a higher mortality, 6-month mortality, had reduced ventilator-free days, and increased risk of pneumothorax when compared to the PEEP titration based on FiO2. What we are taught as intensivists is find the lower inflection point, set the PEEP above the lower inflection point on the pressure volume loops, And it sounds very simple, but here there are some logistic issues. You need a paralyzed patient, and there are challenges in determining the exact LIP on the pressure volume curve. And there is a study which says the clinicians tended to disagree widely, and this disagreement could be as wide as 10 centimeters of PEEP. Now, it is also known that recruitment of lung does not occur uniformly just at the lower inflection point, but across the entire loop of the curve. So that is the challenge with the LIP. And it's also known that 30% of the alveoli can remain closed even at 30 centimeters. There's a lot of interest now on what they call loop tidal volume hysteresis. Now, intratidal recruitment results in increased compliance of respiratory system during insufflation, and bedside lung recruitability can be assessed using static PV loops obtained during low flow inflation-deflation maneuvers. Now, the area of the hysteresis, that is what is shown in the lower one, actually correlates with lung recruitment. The one on the right hand side is what you normally see in ARDS, and what you're trying to do is move the curve from the left to the right, from a more convex to a concave type of PV loop. And this area of the hysteresis can predict those who are amenable for recruitment. So there was a recent article which looked at decremental PEEP in 38 COVID patients, and they demonstrated 3 models of patients, 3 patterns. 26% who had consistently high tidal volume recruitment, which is the one on the left. 31% who had consistently low recruitment, which is on the extreme right, and the one on the middle was 42%, who had a biphasic type of curves moving from low to high tidal volume recruitment below a certain PEEP. And this study showed that a tidal hysteresis of more than 100 ml highly predicted tidal recruitment. There is also a lot of interest on CT-guided PEEP titration. Technically, logistically, this is difficult, but this study published in 2014 looked at 51 patients with lung recruitability and CT-derived PEEP values. These studies surprisingly found that lung recruitability and CT scan-derived PEEP values were unrelated. And to overcome compressive forces and lift up thoracic cage, a similar PEEP was required in both high and low recruiters. And as I said, there are challenges in taking a patient down for CT, radiation exposure, and all the logistics of an unstable patient. But what was interesting, based on study by the same authors, was that they looked at 148 ARDS patients and did a CT assessment looking at lung edema and recruitability, and a 3-step assessment at what they call clinical PEEP, which was determined by the clinician, and at 5 centimeters and 15 centimeters. And what was quite interesting was that when they dialed down the PEEP to 5, they found that 54% of patients who were actually classified as mild ARDS had to be reclassified as moderate or severe. And once they did that, they found that the lung recruitment or recruitability linearly increased with ARDS severity. This is important because we often make the mistake of saying this is mild ARDS with a patient sitting with a PEEP of 10, whereas actually if you titrate it down to 5, then you know whether they are mild, moderate or severe, and the severe ones are more recruitable. There's a lot of interest on ultrasound-guided PEEP titration, and there are several studies on this. One study that I picked up from the Blue Journal looked at 12 regions, 30 ARDS patients and 10 ALI patients, and looked at different lung entities, consolidation, multiple irregular spaced B lines and multiple coalescent B lines and normal aeration, and they found there was highly significant correlation between PEEP-induced lung recruitment by PV curves and ultrasound reaeration score. A bit of caution here, we said PV loops are not ideal, but this is the correlation that was done in this study. Now, transpulmonary pressures have been around for a long time. They are, the transpulmonary pressure corresponds to the distending forces applied to the lungs, which results in their mechanical deformation. And due to its anatomical position, the esophageal pressure can be used as a surrogate of pleural pressure. This is an RCT that has compared esophageal pressure group versus conventional therapy. The study was terminated early because the PF ratio at 72 hours was higher by 80 to 88 millimeters in the treatment group than control group and persisted throughout study. So a titration using transpulmonary blood pressures seemed to be better than conventional ways of PEEP titration. Now there are several advantages and disadvantages of PEEP titration using transpulmonary pressures. It offers a more accurate assessment of stress on the lung parenchyma, and customization of PEEP and tidal volume is possible. It's fairly non-invasive, and you can use it in obese patients and patients with high intra-abdominal pressure. But it has its own disadvantages that it needs correct balloon position. The heterogeneity of ARDS may make it challenging, and it's difficult to do it in prone patients or difficult to estimate, and it can overestimate pleural pressures in well-aerated areas. The last modality, which is probably the most interesting and promising modality, is the electrical impedance tomography. This is a non-invasive radiation-free imaging tool to monitor real-time distribution of ventilation. It is done by passing small alternate electrical current through 8 to 32 equally spaced electrodes around the thorax, and the lighter the color, the greater the regional ventilation. And the modern machines can generate up to 50 images per second. And the inflation, as we know, occurs heterogeneously from the ventral to the dorsal and from inspiration early to late. Now, this is a model which shows the ventilation at a PEEP of 5 as well as a ventilation at a PEEP of 15. As you can see, there is more homogeneous ventilation when the PEEP is at 15, which is a right-hand side EIT imaging. Now, there is a method that they have developed to estimate pulmonary collapse and overdistension using regional image information. So what EIT does is it gives you an information of the proportion of alveoli that are overdistended and the proportion of alveoli that are collapsed. So in this image, we find that the best compliance of 26 was achieved at a PEEP of 17, but at this level there was no collapse, but 13% of alveoli were overdistended. The least collapse of 5% and overdistension of 5% was achieved at a PEEP of 15. So what this shows is that if you're going by compliance and trying to titrate, you may actually cause more overdistension. But if you use electrical impedance tomography, you may get the right balance of overdistension versus collapse. There are studies that have also looked at it. For lack of time, I'll just skip through that and then go on to a practical approach. What do we do at the bedside? We normally intubate the patient, start with low PEEP titration, and then dial up or dial down and try and get an optimal PEEP, which results in good oxygenation. But in more complex patients, we may need to look at other modalities of measuring, of optimizing PEEP. So to summarize, PEEP can be targeted based on oxygenation, based on compliance and recruitability, or the balance between overdistension and recruitability. There is no gold standard for PEEP titration because we have the challenges of heterogeneity in ARDS, but electrical impedance tomography is a promising tool for optimizing PEEP and tailoring PEEP according to the ARDS severity with the ARDS severity classified at a PEEP of 5 seems to best correlate with recruitability. Thank you.
Thank you, sir, for that insightful session. For want of time, we will take all the questions at the end of the session. Moving ahead, we now have Dr. Suresh Ramasubram, Specialist Pulmonary Respiratory Medicine, Apollo Multispeciality Hospitals, Kolkata. He will be delivering his talk on recruitment maneuvers in ARDS, an updated thing.
Thank you,
Over to you, sir.
Thank you, Chairpersons. I'll start off with the same thing as last evening's statement of Suresh Ramasubban, modification of Zig Ziglar. Repetition is the mother of boredom, but mother of learning, but father of boredom, and it's the architect of success. So there is going to be a lot of repetition in what you just heard, but it's fair enough that we do that. I'm not going to show you this definition because for my talk, I think you need a different definition of ARDS. This is a clinical definition of ARDS, which doesn't make sense when we talk about PEEP and recruitment. So to understand PEEP and recruitment, we need to have this definition of ARDS, which is a very old definition, Mike Mathis definition of ARDS, which looks at basically ARDS as somebody who's got an altered permeability pulmonary edema. It's not, so that itself tells you that's not cardiogenic pulmonary edema. It's not a hydrostatic pulmonary edema. And there's a decreased gas volume, so there's a decrease in functional residual capacity. And this leads to a low respiratory system compliance. That means your change in volume per unit change in pressure is less. less, and this leads to hypoxemia due to two things, that is an intrapulmonary shunting and a VQ mismatch. And what we are going to try to do with PEEP and try to do with recruitment is to alter the intrapulmonary shunting. So this is a physiological definition of ARDS, which is very useful in understanding how we proceed with ARDS when we talk about PEEP and recruitment maneuvers, as compared to the clinical definition, which is the Berlin definition, which has no meaning when you're looking at how to do these things. All right, as a result of these, so you have basically why there is a decreased FRC. There's a decreased FRC because what we have been traditionally taught is the baby lung model. That means you have somebody who's got areas of lung which are hyperinflated, areas of lung which are underinflated, unstable, and you have which are vulnerable to collapse, and then you have completely collapsed alveoli. So as a result of which you have these three gradation, and then you have to look at these things and say, okay, this is the reason why there is a functional residual capacity. That means the amount of air left in your lungs after a normal tidal respiration, which is FRC, is significantly reduced, and the only way you can improve your FRC is by opening up these alveoli. So the goals of mechanical ventilation in ARDS are very simple, ensuring adequate oxygenation, maintaining an adequate pH, and the third is the utopian goal, that is preventing villi, and we will talk about. To ensure adequate oxygenation, we basically have to increase your mean airway pressure, and that's done by increasing your inspiratory reserve volume or by increasing your PEEP. And so we're not going to talk basically predominantly on that. And for permissive hypercapnia, we now know that any pH more than 7.15 and the concept of permissive hypercapnia as advised by Hickling et al. In 1992 is still very valid. But what is more important when we ventilate these people is the third goal, that is to prevent prevent villi, and that is where whether we need to understand villi, and we have a lecture on ergotrauma where we will be hearing a lot more about stress and strain. But stress is basically the pressure above the transpulmonary pressure, and strain is the resultant change. So it's a simple physical thing. So if you look at the formula of how to look at the what are the various pressures that is involved in the lung mechanics, stress is going to be affected by the elastance, and change in volume by the FRC again. So the compliance of the lung, the FRC, is coming back into this equation to again and again tell you that the best way to decrease villi would be to improve your FRC. The changing stress, changing strain, we'll have a talk on ergotrauma, but what we are saying is, can we use any measures to increase your FRC? Because the moment you improve your FRC, your stress and strain will disappear, and therefore villi will disappear. And that's a very straightforward, simple things to do. And we know that when you ventilate at low volumes, which is leads to lung inhomogeneity like this, end expiration and end inspiration, you have this atelectotrauma, and you also have at high lung volumes, you have air leaks or barotrauma and over distension, and then you have biotrauma. All these things can happen because of long this thing. So focusing a little bit on atelectotrauma, this is the Meads model of lung stress. So this clearly points out that at the interface between the collapsed alveoli and the pointer somewhere, all right, the small black spot that you have, there is going to be a significant difference in the pressures that you will be able to. So at this point in place, the totally collapsed unit versus a high stress versus an intermediate stress, and the green one would be the high stress areas. So this is the Meads model. So what it's saying is that the volume ratio in a fully expanded unit and a fully collapsed unit is 10:1. So that is very obvious to see. This volume ratio between this and the fully open is almost 10:1. That's the kind of ratio that you're seeing. And for a surface ratio, surface area is 10/1 to the power 2/3, which is 4.64. So what it translates to is that if your transpulmonary pressure at this area is about 30, plateau pressure of 30, you're going to multiply this at this small collapsed area by a factor of 4.64. So as a result of which, a transpulmonary pressure of 30 results in a transpulmonary pressure of 139 centimeter in a closed alveoli. So this is the physics of why you are trying to open up a closed alveoli, and this is what leads to the use of PEEP and to mitigate lung injury. So when you talk about PEEP, we talked about PEEP as an oxygenation tool, but we also have talked about PEEP to mitigate villi by recruiting the alveoli, decreasing the amount of atelectotrauma, and so on. And this led to the concept of protective lung ventilation, which we are very well aware, but it also led to this concept as proposed by Amato et al., the concept of an open lung. So to open the lung and keep it open, you have to have PEEP has been combined with alveolar recruitment. Dr. Peter just talked to you about PEEP. So what is the idea is that you're going to open these lungs, reduce the interface between the open and aerated lungs and minimize atelectotrauma. That is the fundamental principle of opening up the lung, is to improve your FRC, therefore decrease your villi, and therefore have better oxygenation, better compliance, and therefore have less villi, and therefore have a utopian goal of all our patients surviving and going home. So that's exactly the concept. So the definition of recruitment is basically re-expansion of previously collapsed lung units by means of a brief and controlled increase in transpulmonary pressure. So this is the definition when we talk about recruitment, is that I am trying to open your lung and keep it open, and that's blah, 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 blah. If you've seen all those small models of pig models where we open up with this thing, you'll see all these alveoli and lung models opening, blah, 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 blah. You'll hear the noise, and that's the utopian goal that we want to do it. So what is it that we are doing, trying to do is there a relationship between alveolar volume and pressure and alveolar shape and size, and how does volume change this thing? So this has been a period of interest from the 70s. So you have different pressures trying to open up an atelectatic. So what is the pressure which will open up my atelectatic alveoli, and how long do I need to give this, is the question that has been asked for many, many years as to what is the exact thing. So in alveolar recruitment, there are two fundamental concepts. One is, how much pressure do I need to open up your alveoli, and how long am I going to do it? So therefore, people who are following the literature on ARDS will tell you that you will find data on two things: sustained inflation maneuvers and brief inflation maneuvers. And that is why this mechanism comes to, because the alveolar recruitment is basically, the idea is when you increase the transpulmonary pressure, you have what is the closing pressure of various alveoli, or the threshold opening pressure. You got to get that up. And once the critical opening pressure is achieved, you got to keep it open by doing it for a sustained amount of time. And this will varies from region to region. So based on the open lung theory, it is considered that the entire lung mass can open. I don't know how many of you have heard Professor Lackman when he came in the first 2000 conferences in critical care in India, and when he will show this, that you have to get a PaO2 of 590 to get a real, that is when you say your lungs are recruited. So he would actually, the first lecture in critical care that I had in ISCCMs was from Professor Lackman from South Africa, which will point out that you have to achieve a goal of PaO2 of 500 plus, then only you know that you've got a good recruitment. And this is where, so what is the pressures? They will say the mean average amount of pressure that you require is somewhere between 40 to 50. How do we know that? We know this from Gattinoni's study, which we know that the potential, the best recruitment is a Gaussian distribution, where from 30 centimeter onwards to up till 45 centimeter, you get maximum opening of the alveoli. So when we talk about what is the pressure that is required to open an alveoli, open all the alveoli like in this situation, it's about 45 centimeter of water, because the moment you go above 45, you have hemodynamic consequences that come true. And that is what is this thing. So this is a CT way of knowing what is the correct pressure to do it. And we talked about the pressure volume curve and the hysteresis. Dr. J.V. Peter just mentioned that one of the other ways in looking at a recruitment is to say, analyze the pressure volume curve, and not the fact what's the lower inflection point, what's the upper inflection point, but look at the hysteresis, that is the gap between the inspiratory curve and the expiratory curve. The hysteresis actually refers to how much is your recruitable lung volume. So this also can be a good way of identifying whether you are recruitable or not. And when you give recruitable this thing, you find that when you do these kind of study, you will find that the pressure at which there's a maximum difference or a maximum hysteresis is again about 45 centimeter of water. So this is the anatomical recruitment that you can watch on a CT or watch on a pressure volume curve. And you obviously get a functional recruitment, and this is by the increased oxygenation. As I said, Professor Lackman and all would try to achieve a PaO2 of more than 500, and this is what is the concept behind the alveolar goal. So how do we eventually achieve this alveolar recruitment? And the alveolar recruitment answer is very simple. I like all my clinical medicine talks to start with the same thing: treat the underlying cause. Because if you treat the underlying cause, a lot of problem will go away. So sometimes bronchoscopies are very useful if you have a little mucus plug. Diuresis works very well if you have fluid in the alveoli, and so on. But we need to talk about, prone positioning is probably the number one recruitment maneuver, which is has been shown to have the maximum benefit and which we most commonly use. Sigh ventilation is also making a back. If I don't know how many of you have used the old Siemens ka dabba wala washing machine kind of ventilator, which had the inbuilt, which had the inbuilt psi maneuvers in which you could put in. So all those things are coming back because of these things. Airway pressure release ventilation is also one more way of recruiting things. But we're going to talk about the standard recruitment maneuvers which we have been taught about. This is the two maneuvers that we are talking about, a short duration and a high duration. The short duration is 40 centimeter of PEEP for 40 seconds, and that's the standard one. But the one which has been used in the ART trials and which is now called the stepwise recruitment maneuvers, that means you start with a PI put the patient on a pressure control mode, set the PI at 15, start your PEEP at 5 and then keep on increasing. Always keep the difference between pressure control and PEEP at 5 and keep on moving up till you hit the best compliance, until your driving pressure drops. Then you start decreasing your PEEP till you find where the driving pressure is appropriate. And this is done every 2 minutes. So you're going to have sustained, or every 1 minute, depending on which hospital or where you work. And this you're going to get a response. There is going to be a variability in response. Depends on the etiology, what phase. If you're in the fibrotic phase, it's not going to work up. It might not work up when you're more recruitable versus less recruitable. Patient positioning, prone versus supine. What are the various vasoactive drug, and how's your chest wall expansion? All these things is going to make it. So in routine practice, we only do it as a rescue measure, but then the open lung theorists wanted us to use it as an early thing. So if you look at the responders, what do you mean by responders? That means you have a 20% increase in your PF ratio, or at least 50% after a maneuver is called as a positive response. And these are the number of studies which have been done. There has been the systemic analysis. We know the compliance gets better. We know the oxygenation gets better, but we know that there is no improvement in mortality. But in the context of open lung ventilation, after these meta-analysis in 2009 and 10, we had 2 papers published in 2011 and 2015, which said that the staircase recruitment maneuver might make a difference. So then the ART trial came, and the ART trial has now demonstrated that it's actually harmful when you do these 3 cardiac arrests during these maneuvers. So they had to interimly stop the recruitment for the study, and they had to change the stepwise recruitment maneuver. So we know that the ART trial caused harm, especially during these prolonged recruitment maneuvers. So therefore the ESICM strongly recommend against the use of prolonged high pressure recruitment. So should we go back to the 2008 and 9, the low pressure ones? And the answer is to that also is that for the brief high pressure recruitment maneuvers, they have included 3 more new analysis: the Kasmerak study, the LUBS trial, and the Xi from China. And again, they say there is no improvement in outcome as far as even for using brief high pressure. So recruitment is both pressure and time. And we have now demonstrated clinically in many clinical evidence that though we might improve oxygenation, we might improve compliance, there is no change in outcomes of the patient, and there might be harm, especially with a sustained high pressure recruitment maneuver, while sustained low pressure doesn't cause any harm. So that is why the studies in OLV have failed, especially. So despite the big belief in open lung ventilation, we are not able to get experimental clinical evidence of its benefit, except from the Amato study, which was the initial one which showed benefit. So I can stop here, but since I have 40 seconds, I'm just going to open it to a debate, and probably a good debate. So is there something called a skeptical look on the opening and closing story? So is there an alternative theory for what is happening, and can we close down the lungs and keep the lungs closed? And should this be a maneuver rather than trying to open the lungs up? So that is basically to reduce the injury in atelectatic lungs. We can reduce inflammation. We have what is called as a concept of permissive atelectasis. So maybe instead of trying to recruit in 2024, we can think of what is called as permissive atelectasis. Not really the goal. Basically, the idea is to say, if I can't do you harm, let me just not interfere. It's called ICU medicine by people who do not have knowledge about ventilation. So fair enough. It's a very good approach to, when you don't know anything about too much in detail, just don't near it. And maybe something to look at, but my topic was to say, what is the status of recruitment maneuver in 2024? And the answer is, forget about it. Thank you very much.
Yeah, thank you, Dr. Ram Subban. That was an excellent talk on just the complex context. We'll take the question at the end of the session. I now request Dr. Ghanshyam Jagatkar, who is a director and senior consultant in Medicover Hospital, Hyderabad. He will be dealing with optimizing airway occlusion pressures during mechanical ventilation. How do I do it? Over to you, Dr. Ghanshyam.
Good morning, and at the outset, thank the organizers for having me over here. Uh, think our interest in airway occlusion pressures has been reignited. If you look at data, I think we have been looking at airway occlusion pressures for the last 40 to 50 years. But recent incriminating evidence suggesting that respiratory drive could be a potential factor influencing lung and diaphragmatic injury is something which made us look back at the airway occlusion pressures. So when we look at the basic respiratory physiology, the respiratory center in the brain receives multiple stimuli from different parts of the body, predominant among which is your chemoreceptors, which are again stimulated by your PaO2s, PCO2s and the pH. And once the respiratory center gets these inputs, an electrical stimulus is given to the mechanism of breathing, right? So you have the respiratory center, and depending upon all the inputs, there is a stimulus which goes to your upper cervical nerve. From there to the muscles of respiration, that is the diaphragm and the other respiratory muscles. And the intensity of the output determines how strong your respiratory effort or your inspiratory effort is going to be. So to put it in a very simple way, if you have a very strong respiratory output from the nerve centers, you have a very strong inspiratory effort. So whenever there is a change in the respiratory drive, that will induce a parallel change in your minute ventilation. So if you have a very strong drive, your minute ventilation increases, and if you have a very low drive, your minute ventilation decreases. And that is what has been shown in the recent data, that this respiratory drive influencing your inspiratory effort will have an impact on your diaphragmatic and lung injury. Now, we have always tried to look at, can we measure this electrical output which comes from the brain, but it's very technically very challenging. So we have looked at alternatives of measuring the mechanical output, and that is what we are trying to look at in this specific talk. Now, the two curves. The first curve basically shows a relationship between your metabolic curve and your minute ventilation. We know that carbon dioxide is a very strong stimulant for your breathing. So depending upon your metabolic condition, there is certain amount of carbon dioxide which is produced in the body, and that stimulates your minute ventilation. So ultimately a steady state is reached between your stimulation by carbon dioxide and your capability of the respiratory system to drive that out. Now that's what happens in a normal condition. Now there are other factors like your acid-base balance, your pain and anxiety, which also have an effect on your respiratory stimulation. Now when you look at the other graph, now this is what happens in a healthy individual. Now depending upon your basic metabolic conditions, certain amount of carbon dioxide, I have only used carbon dioxide as one of the parameters, though there are multiple other factors which can influence or which can stimulate your respiratory drive. Now in healthy individuals, based upon the metabolic conditions, certain amount of carbon dioxide is produced, and the brain stimulates your respiratory center to have certain amount of minute ventilation so that it maintains the carbon dioxide within a normal range or within an acceptable range. So there is a synchrony between what your brain wants and what your minute ventilation can achieve. But when it comes to critically ill patient, your metabolic conditions can change, thereby your basic carbon dioxide within the system can increase, and that stimulates your brain, and your brain wants certain amount of carbon dioxide. But parallelly, in critically ill patients, your respiratory system may not be in a position to match what the brain needs. And that is where you have a dissociation between what your brain wants and what your ventilation can actually achieve. And this dissociation is what we usually perceive as dyspnea. Now, when you put these patients on mechanical ventilation, the way you set your ventilatory parameters determines what happens to this gap. So if your ventilatory parameters are in sync with what your brain needs, you will find that the brain curve and the ventilation curve come together as what happens in a normal patient. Now, if you give overventilation, then there is a chance that your ventilation curve may go beyond the brain curve, or parallelly, when you give lesser than what is needed, this dissociation may increase further, leading to further respiratory distress and further respiratory drive. So why do we need to measure or monitor the respiratory drive? Because, as I've said, respiratory drive on either side is bad. If you have a very high respiratory drive, that will translate into higher or stronger inspiratory efforts, and we have known that patients who have very strong inspiratory efforts, especially during spontaneous ventilation, can lead to self-inflicted lung injury. At the same time, vigorous inspiratory efforts have been shown to cause significant myotrauma to the diaphragm, which you want to avoid. These things can also lead to hemodynamic compromise, especially in critically ill patients, can also cause patient ventilator asynchrony, especially if you are in ventilator volume modes, leading to double triggering. And we know that if you have a very high respiratory drive, that can lead to weaning and extubation failure. Now, on the other extreme, if you give too much of ventilatory assistance and you completely inhibit the respiratory drive, even that has shown to have negative effects, mainly in terms of disuse atrophy of the diaphragm, sleep disturbances, your apneic spells, and patient ventilator asynchrony. So you need to ensure that your respiratory drive is within the physiological limits. You don't want a very high respiratory drive and you don't want a very low respiratory drive. And that is the reason why we try to see if we can measure respiratory drive at the bedside. Now, there are different techniques which have been suggested. The gold standard is the esophageal manometry, the changes in the esophageal pressure, but many times it's very difficult to have the infrastructure where you can measure the esophageal pressures regularly. The other, which is something which is very accurate, is your electrical activity in the diaphragm. Again, there is something which is not very easily available and not something which can be easily measured at the bedside. So that is where we look at the airway occlusion pressure within the first 100 milliseconds. That is nothing but the P.01. Now, the advantages of P.01 is it is something which can be measured non-invasively. Most of the ventilators have this displayed automatically, and there are trials where they have compared P.01 with your gold standards like your electrical diaphragmatic activity as well as the esophageal pressure, and they found that P.01 correlates very well with measures of respiratory drive as measured by the esophageal pressures. It was also shown that P.1 can detect potentially injurious inspiratory effort. Now, because you are measuring the airway occlusion pressure at the end of expiration within the first 100 milliseconds where there is neither flow nor change in lung volume, it is not influenced by the respiratory mechanics. So even if the patient has bronchospasm or if the compliance is less, the P.01 is not influenced because you are measuring it at a point where there is neither flow nor change in volume. And there was some concern of whether does it reflect accurately in patients with COPD with autoPEEP, and the trial by Conti suggested that it is a reasonably reliable parameter to measure respiratory drive in patients with airway occlusion, and it was also shown that you can use this in patients with moderate to severe muscle weakness. The only point we need to remember is if you have to rely on airway occlusion pressures, then the arc between your neural center and the diaphragmatic or the muscles of respiration should be intact. Anything which changes this arc, your airway occlusion pressures become unreliable. So that's what your airway P.01 makes it very simple and interesting. It's available in most of the ventilators. Most of the ventilators display an automatic measurement of this parameter. It has been shown that different ventilators, the way they measure P.01 was fairly comparable to the reference standard. Okay? So that's what makes it very interesting. What is the range? In normal healthy individuals, somewhere between 0.5 to 1.5. But for all mechanically ventilated patients, the accepted threshold is anywhere between 1 to 3.5 up to 4 centimeters of water. Because there is a breath to breath variability, what is recommended is you take an average of at least 3 to 4 measurements, and then you interpret that as the final value. And data has shown that with respect to lower or diagnosing a decreased respiratory drive, it has got excellent accuracy, and for diagnosing a higher respiratory drive, it is fairly good and reliable. Now that brings us to the question of, once we diagnose a abnormal respiratory drive, what are the solutions we have? Now the most common intervention that we can think about is using sedatives. Now there are different types of sedatives that have been proposed. You have opioids, you have alpha-2 agonists, but the most profound effect on the respiratory drive has been shown to be with propofol and midazolam. As I have shown, among the multiple parameters which can influence your respiratory drive, pain and anxiety is a very significant parameter. So modulating your sedation requirements is something that we can always do. The other thing that we can think of is looking at extracorporeal carbon dioxide removal. As I've said, carbon dioxide is a very strong stimulant, and if your conventional ventilatory methods do not normalize your carbon dioxide, you can look at extracorporeal removal. Modulating the amount of pressure support that you're giving. Again, inadequate pressure support has been shown to be a strong factor in influencing your respiratory drive. And if you have a patient where there is extreme heterogeneity and bad lung compliance, then you can also look at prone ventilation as a strategy of decreasing the respiratory drive. And non-conventional techniques like use of music has also been shown to have some effect in relieving the anxiety. So to summarize, respiratory drive is a very important factor which influences both lung and diaphragmatic injury. And when we talk about lung protective ventilation, it's not just about low tidal volumes or keeping a watch on the driving pressures or limiting your plateau pressures, but we also need to look at what's happening with your respiratory drive. And airway occlusion pressures are something which are very reliable, easily available, non-invasive, bedside techniques which are available in a majority of the ventilators, and which can give a fairly good idea of not only your respiratory drive but also the inspiratory effort, which can be a incriminating factor in your lung and diaphragmatic injury. Thank you.
A small announcement.
Thank you, Ghanshyam. It was indeed a good presentation. In fact, this is the same thing which we teach every day. So that is very nice. Any questions are there, we will take at the end of the sessions.
A small announcement. There is a breakaway session happening in the Hall B on panel discussion role of amitriptyline in ARDS. Those who are interested can join, please.
Right. Now move on to the next session. This is the in-thing, what is happening in Bangalore, that is especially AI. So now we will listen to AI algorithm in mechanical ventilation by Dr. Raymond. So who is a lead consultant in Apollo Hospital, and he has fascination towards organ dysfunction and sepsis and infectious disease. So over to Raymond.
Thank you, Chairperson. I'm afraid if AI made the Apollo as Apollo. Anyway, a very good morning to everyone. Cheers to the organizers, and thanks for having me here. Artificial intelligence algorithms in mechanical ventilation. I was fascinated, although I have no personal experience of having handled them. I have fidgeted with a couple of machines, although I've never used them in clinical practice. It was a happy learning for me, that's all, okay? So that's a disclaimer. And it's going to be more of an eye-opener, lighter session or an icebreaker session compared to the previous talks that you've been listening from the morning. But then, trust me, all that what they've been talking is probably going to become redundant. All you need to know is to switch on and switch off your ventilator. Or maybe you don't even have to do that in future. I see a lot of young faces, and that's what we are heading to. Okay? Especially because we all agree that AI is the way forward, is the tool to improving patient care by optimizing, or more rightly put, personalizing patient care. Because from morning we've been talking about phenotypes, subphenotypes, differential response, precision medicine. So much of data has to go inside to get processed, and it's going to be beyond the scope of human intelligence to be able to do that, especially in an data-rich environment like an ICU. So if at all there is any area in clinical medicine that's really going to benefit from AI, leave alone the Pro Health and the Master Health checkups. Those are already immensely benefiting from artificial intelligence. I don't even have to talk about that, okay? And that's beyond the scope of today's lecture, of course. So this is what we're going to quickly run over the next couple of 10 slides, that's all. Not too much of information, just an eye-opener, okay? So what do we have in critical care per se? Currently in the market, a whole lot of predictive analytical models are there, prognostication models are there. Some were already discussed in some of the previous sessions also. Some clinical tools have also come in, like sepsis resuscitation tools are there still. There are many more under development and in their validation phases. Now, there is a fundamental limitation when it comes to AI algorithms in mechanical ventilation, because it's not so easy to feed in data. Basically, you need to get the world of data into the machine for it to learn, okay, to be able to give you what they call as a clinical decision support system. You're going to be hearing more of the CDSS. People out there in the stalls are going to probably be telling you AI jargon, all that is. So let's see what we have in store. Yes, in the last couple of decades, we've had these really good intelligent ventilators, okay, but are these artificial intelligence, those that run closed loop systems? No. We've all used most of these. May not be that much of NAVA, but the rest of them, I'm sure we all have had our hands on. Brilliant systems. But these are basically advanced software programs that execute a certain loop of action based on what you have told it to behave like. This is not artificial intelligence. So you need to fundamentally understand that artificial intelligence should possess the characteristics of an intelligent being. Okay? It should be able to perceive the environment. It should be able to set its own rules of behavior. And it should be able to improvise on its behavior with experience, exposure, further learning, feedback. We all have used ChatGPT. Every single question you ask and every correction you make is its learning process. So that's how you need to really have an effective artificial intelligence algorithm for mechanical ventilation. So are we there yet? Maybe we are moving towards there, and these are not artificial intelligence. So where does all this intelligence come from? What we call as machine learning. I already told you, so a whole bunch of data goes in, whatsoever data of any sorts. Okay, so for this, fundamentally, we need to have these systems all connected to your server that is learning. Input from pathology, radiology, biochemistry, all your ABGs, from hemodynamic variables, everything needs to go in to be able to make any sort of a meaningful autonomous algorithm. Until that happens, until that becomes a reality, we are still going to be calling ourselves as nascent. So this machine learning, again, we're not going to go too much into the depths of this, can be supervised or unsupervised learning. Supervised learning in its simplest form, you tell the system what is the intake, what is the output, and this is the behavior. So the learning happens in that pattern. Okay, I don't know if that made any sense. Unsupervised is, you give in all sorts of data. There may be any sort of association or not. You just throw in junk and the machine starts to find associations, and you may land up seeing some incredible, unacceptable associations with or without any rationale behind. Okay, so with all these kind of supervised and unsupervised learning that are potentially possible in our ICU environment, let's stream down to the scope of mechanical ventilation. I could sit and fancy about all these applications. Maybe you could come up with more than what I have put up over there. The ones that I've underlined are probably things that are already available in the market. Many of them are under development. You may land up using some of them within the next 5 years also. But those all need to still improvise. Each of those have their own gaps in technology, issues with validation, calibration, predictability, reliability, all those things. Okay, we can keep elaborating challenges and limitations, but this is the way forward. Okay, patient monitoring basically in terms of not just respiratory dynamics, but whatever that you can connect goes into integrating the trajectory of the patient. So you have a real-time assessment of whether what you're doing is correct. Okay? And predictive analysis, if someone has some sort of association with the ProHealth systems, and in fact, Apollo has its own patented algorithms. I was just discussing with some people over here for these master health check based trajectories where you can predict that somebody is going to develop something in this couple of years and you start taking preventive measures. All that is already there. When it comes to mechanical ventilation, will we be able to predict a villi or an infectious complication or some sort of an asynchrony to be setting in? All that is feasible. We do have algorithms in place. Synchronization tools, optimizing settings is basically feedback optimizing. It is there. You may be interested to actually see one such system in the station, the industry zone out there. Anomaly detection, all those things. But by and large, the zone or the area where ventilation related AI algorithms have benefited from are when it comes to weaning. No conflicts of interest. These are all systems that claim to have incorporated some kind of algorithms or the other, either to do with predictive analysis or trajectory analysis or synchronization, feedback control. But by and large, majority of them have something to do with weaning systems. You may want to go and explore something that's sitting out there in the industry zone. G5 has been removed from the market. It's replaced by C6, I was told, and that was smart, in fact, the Intelligent ASV, which is out there for display with the AI. But again, when I fancy an AI, I would imagine they should continue the learning process. They need to be connected to the central server, which should be able to learn. That system is still not available with us. Okay, quickly touching upon a couple of trials that you may want to go and read up. I'm not going to elaborate on them. Interesting systematic review in 2020, I was zapped to see that there were publications about artificial intelligence this is exclusive to mechanical ventilation, okay? Even before I joined MBBS. And the splurge of activity probably happened during the COVID period of times. In fact, there was one Hyderabad-based ventilator company as well that came up with these COVID predictive tools incorporated inside in collaboration with a Dutch unit. I'm not sure if they are still in limelight, but that just took a boom during the COVID period. And we just realized that there aren't too many trials, especially clinical trials. You cannot ask for them already because we are still looking at their predictive abilities, AUROCs, validation, things like that. Okay, we are still in the mathematical modeling and computer science stage. And there's going to be a whole lot of problems, especially a lot of bias with many of these systems, which are so, oh, the color combinations have changed, I'm sorry. Okay, so with specific to weaning, what kind of algorithms do we have? We already have these stuff in the market. Things that come in handy pre-anesthesia, which predict the need for elective post-operative ventilation. For people who handle surgical ICUs, you know the kind of trouble we have when the anesthetist typically pulls off the tube, long hour surgeries, and then you land up re-intubating. Hopefully, all that is done away with. Pre-intubation, being able to predict outcome, how they behave during their weaning protocols, difficulty in weaning, timing of weaning, weaning outcome analysis, all of these are available. Many are under development, some are already hitting the market. If you can afford one for your hospital, you can actually go and purchase. AI for weaning, this is another very recent 2024, more of narrative review. I just recommend, it's a nice read, please go back, look at it. It gives a nice summarization of how they do these validation for these models. If you can see, out of the 16, only 3 were good enough to look at clinical outcomes, and they gave you barely a marginal improvement in clinical outcomes, which could be either ICU length of stay or mechanical ventilation days. We are still not there to create a big bang with these, but we are making steady progress indeed. Other than weaning outcomes or weaning protocols, we have those that automatically go in and make corrections or setting changes with PEEP or FiO2 or tidal volume according to the ideal body weight. Again, the system that's there for display seems to be doing that. This particular evaluation on close to 12,000 volume control even showed that there was statistically significant difference in terms of the number of times changes were made by the AI algorithm as compared to clinicians. Okay, there are several more trials. I didn't put them all up because I mean you know how it's all going to look like. Okay, end point is I'm going to say they still don't have much of a clinical significance. We are evolving, so that's about it. And beyond just doing something like either weaning or either feedback control, I would fancy something like an autonomous system where I told you, you just switch on the ventilator, switch it off, and it does everything. Okay, that is when we call it the real charm of AI, and that I'm sure it's all happening. I don't know how many of us live up to see that. And naturally, you can expect some problems arising out of that. This again is a very interesting read, a case series. I'm done. A case series where they speak about how so many times the clinicians get zapped. The ventilator goes on doing so many things that they don't even alarm because they tend to troubleshoot themselves, and you will be taken back by surprise because many of their predictions may lack a scientific rationale. Okay, and needless to say, we have a whole bunch of these challenges. We can keep talking about challenges. They are going to be there at any stage of development. So we're just going to get better with time. So if you ask me, are we there yet in terms of AI algorithms for mechanical ventilation? Yes, we are making steady progress. There are systems already available for you to use if you can afford it. Of course, they aren't the best in class, but that's where we are getting to. So it's definitely going to take a little more time to translate these, what do I call them, algorithmic data science into deployable scientific bedside clinical application. So until then, let's continue to stay fascinated. Thank you.
Wonderful talk, Mr. Raymond. I think future we'll be having more sessions on AI, or next GIGS also we may have more on AI classes. Questions we'll be taking after the end of the session. Next I'll be inviting Dr. Sanjeev Kumar. He's a professor HOD, Department of Critical Care, and he'll be talking on optimizing HFNC use in ICU. Over to you, sir.
Good morning, everyone. My talk is on the HFNC. Is it included? So the main important thing is that how we have to optimize the HFNC in our ICU. So we talk about oxygen therapy. It is one of the more commonly prescribed supplement of the hypoxic patient, and this supplementation of the oxygen is often done by low flow nasal cannula. Okay. So traditionally nasal cannula can effectively provide only up to 4 to 6 liters per minute of the supplemental oxygen, and we should know that the FiO2 delivery is directly tied to the flow rate, and this only occurs approximately 4 liter increment seen with the every 1 liter of the oxygen flow, and above this flow, the supplemental oxygen flow, the nasal mucosal irritations occur, and if you use prolongedly, it may sometimes bleeds. So we should know the limitations of this nasal cannula, that in trachopneic patient with the acute respiratory failure, the peak inspiratory flow rate is usually high and often exceed the oxygen flow delivery by the traditional oxygen device. So a high respiratory rate can generate significant entrapment of the room air in the mask and dilution of the inspired oxygen with an insufficient oxygen concentrations. So HFNC is capable of delivery of the 100% of the humidified and heated oxygen with a flow rate of the 60 liter per minute and greater control over the delivery of the FiO2, which is the real benefit of the HFNC. So HFNC oxygenation has the distinct advantage over the oxygen device because it has a unique effect on the respiratory physiology. So these are the basic component of the HFNC. I am not going to detail all of You are aware about this thing. But main thing is that how we have to optimize the HFNC. For that, first of all, the nasal prong should be not totally occlude the nostrils. That is the main thing. Most of the time you see that the nasal prong is occlude the whole nose and the patient feel the suffocations. And we have to set the flow rate, and for that we have to start the flow according to the rate of the 40 liters per minute, and adjustment done based on the patient tolerance and improvement in the ROX index or until a reduction in the respiratory rate or a stable oxygen saturations is found. So you know the ROX index. I'm not going to detail about this, but if its value is less than 3.8, in that condition we have to intubate. So gas flow and FiO2 of this FNCO should be adjusted according to the clinical response, and as we have to reduce the FiO2 every 5 to 10% and flow rate 5 liter per minute, and accordingly we have to reassess after 1 to 2 hours. And if you see any labor breathing oxygenation does not improve in the patients, so we have to increase the flow rate up to 5 to 10 liters. So and the same time you have to also monitor the patient and see the response and the different flow rate according to the different flow rate, and to avoid the lung injury and the over distension of the lungs. So use an active form of the humidification for the optimum temperature, usually set at the 37 degrees centigrade and humidity. And sometimes it's come in our mind that when we should remove this HFNC. So when we get the flow rate, patient is comfortable at the rate of the less than at the level of the 35 liter per minute, and the FiO2 is the 40%. In that condition, we can consider the FNCOC removal weaning. So, and if there is no improvement in spite of the using the high flow, and then we have to consider for some better option, and we have to escalate the treatment. So we should also know some basic concept about the physiological dead space. So as you know that FNC wash out the waste gases including carbon dioxide from the physiological dead space, and this physiological dead space contain anatomical dead space and functional dead space. So physiological dead space accounts for approximately 1/3 of the tidal volume, and this allows for the accumulation of the carbon dioxide and the decrease in the available oxygen for dilution. And a high rate in the HFNC deliver volume of the air over what a patient ventilates physiologically, which increases the ventilation and displaces excess carbon dioxide with the excess oxygen. And this allows for an increased PaO2, creating a greater oxygen diffusion gradient and potentially improve the patient's oxygenation. We all are aware about this law, and that the HFNC allow the reduction of the nasopharyngeal airway resistance, leading to the improved ventilation and oxygenation through the application of the positive pressure environment. So on the basically this benefit occur on the basis of this formula. So high flow nasal oxygenation by creating a positive pressure environment dilate the radius of the nasopharyngeal airway and dramatically reduce the resistance to the airflow, and thus increasing the ventilation and oxygen potential. And reduction of the work of the breathing also occur if we give the effective HFNC. And there is also seen that there is the high flow of HFNC also increases the tidal volume and the in expiratory volume. A high gas flow reduces the variability of the room air entrapment, and also when respiratory pattern vary, so there is the constant FiO2. So warm and humidified air reduces the viscosity of the tracheobronchial secretions and enhances the mucociliary clearance and reduces the dryness of the upper airway and generally improve comforts. And this HFNCO provide the PEEP to the lower respiratory airway, and this effect is similar to the CPAP in that it's apply a splinter force to the prevent collapsing of the alveoli during the exhalation. And this improves the alveolar recruitment and increases the effective available surface area of the gaseous diffusion. But patients have to keep their mouth closed and to gain this maximum benefit of the PEEP from the HFNC therapy. And approximately, it's seen that the magnitude of the PEEP is generated with the closed mouth is about the 1 centimeter of the water pressure for every 10 liter of the flow. But it is difficult to patient to keep their mouth closed when they are in the respiratory distress. So these are the advantage of the oxygen HFNC. So I am not going to detail, but you should aware that it decrease respiratory efforts, increase comfort of the humidification, improve mucociliary clearance, decrease air environment, decrease respiratory rate, and like this thing. So these are the disadvantage. Anything is not without any disadvantage. So sometimes you see that there is a nasal mucosal irritation, discomfort, alteration of the smell, and we also pneumothorax in children, feeling of hot and like thing. So, and also not possible in patients who have the copious nasal bleeding and recurrent nasal trauma. And we can use this HFNC in the various conditions like HFNC, acute hypoxic respiratory failure, post-surgical respiratory failure, acute heart failure, pulmonary edema, hypercapnic respiratory failure, and pre and post-extubation oxygenation, obstructive sleep apnea. All are the, I think you all are aware, but we can also use this thing in the invasive procedure and palliative care, and sometime in comfort care when the patient is ready for the patient attendant is ready for the DNI. So HFNC improve oxygenation by the reducing the cardiac afterload through the generation of the low intrathoracic positive pressure. So there are the various trial and study on this HFNC. I'm just highlighting few of these things. One of the important is the floral trials. Floral trials is the found that the patient who received the HFNC therapy experienced reduced mortality both in the ICU and at the day 90. And there was increased ventilation-free days, degree of the comfort, and reduced dyspnea severity, and the decreased respiratory rate without significant adverse effect. And another trial is the HIGH trial, which is the randomized clinical trial. This trial also shows that the increased mortality when undergoing endotracheal tube intubation due to the increased risk of the infection in immunocompromised patient. And this HIGH trial did not show a significant decrease in the 28-day mortality and the reintubation rate when compared with the HFNC to the standard oxygen therapy without significant adverse effect. So another meta-analysis done by the Huang in the 2018, and that study was aimed to evaluate the effect of the high-flow nasal oxygen therapy compared with the other oxygen technique. And this concluded that the HFNC significantly improved the outcome of the acute respiratory failure in immunocompromised patients. So it also suggested that compared to both low-flow nasal oxygen and NIV, HFNC therapy might be significantly reduce both mortality and intubation rate. So we already we know the physiological dead space. I'm not going to detail about this thing, but if we talk about another study, that is the Thrive administered by the HFNC associated with jaw thrust by the extend the safe apneic window and could possibly change the nature of the difficult intubation from the hurried and the smooth events. And another study was done by the Harmadej that is published in the JAMA in 2016, and this study was done in the post-extubation period. So a study in the post-extubation as the high patient by using the alternate HFNC with the NIV improve outcome compared to the HFNC alone, especially in case of the obesity. And so, and another post-extubation study, especially for the Young Fen Zhu et al. In 2018 shows that HFNC could reduce the need for the respiratory support compared with HFNC in cardiac surgical patient. And the Renovate trial is also important, which show that the HFNC
Dr.
therapy
Sanjeev,
improves.
can we go to conclude this
one,
time?
one slide, sir. HFNC therapy improved the compared with HFNC patient-centered outcome. So, and another study also, but I am not going to detail about this thing. But finally, we can conclude that the patient with the mild to moderate form of the hypoxic ARFA has the most likely to benefit from the HFNC, and HFNC can be used in patients in whom have the standard oxygen oxygen therapy fail, and who need escalation of the NIV prior to the invasive mechanical ventilation, and we can also use ROX index for the identify HFNC therapy failure and need for the early intubation. So, thank you, sir.
Yeah, thank you, Dr. Sanjeev, for that talk, which has actually added a new equipment in the last probably post-COVID era in a good way in acute hypoxemic respiratory failure, extending to others. Now I request Dr. Subba Reddy K, who is heading the Department of Critical Care Medicine in Apollo Hospitals, Hyderabad. And he has been very passionate about neurocritical care. And he will be talking us today about demystifying ergotrauma in mechanical ventilation. Over to you, Dr. Subba.
Thanks, chairpersons, for that nice introduction, and thanks to Pradeep sir and JIGS team for having me here. So I'll be talking about demystifying ergotrauma in mechanical ventilation. So the ergotrauma concept is evolving, and then it is from 2016, and we are talking more about stress and strain for a patient who is on mechanical ventilation. So we know the mechanical power. The mechanical power is nothing but the energy delivered per unit lung and per time to the respiratory system per unit time, and it depends on multiple factors. Not only we were discussing about the pressure, we were discussing about the volume. Not only on the pressure and volume, when you if you know the physiology of stress and strain, and then it depends on, if you look at the equation of the mechanical power, it takes respiratory rate into consideration, the number of times you ventilate the lung, the respiratory rate, tidal volume, and then the resistance and flow, which causes rheotrauma, the amount of flow you give and how fast you give that flow, that is the strain rate. And then the volume by tidal volume by the compliance, PEEP, everything leads to barotrauma. And this chronotrauma, volutrauma, barotrauma ultimately leads to the biotrauma by causing the inflammatory cytokines release, and then causing the biotrauma and then the MODS, and then that is the ultimate reason for the mortality. Since 1979, the first barotrauma concept evolved, and then we thought the high tidal volumes are causing the volutrauma. And 1997 onwards, we started using PEEP to counteract the atelectative trauma because of the cyclical opening and closure. And then from 2016 onwards, we're talking about stress and strain, and then the ergotrauma. And some slides may be repetition, so I will not be using. I will skip those slides. And so when there is ventilator-induced lung injury because of the stress and strain, there will be microfractures in the lung, because it is the lung is made up of elastin and collagen fibers, and the microfracture, cytokine release, increased capillary permeability, alveolar hemorrhages, and ultimately leads to pulmonary edema. And this is both because of the combination of the ventilator parameters and then the lung parameters. We know ARDS lung is inhomogeneous, and then the baby lung, and then there is a collapse, significant amount of the lung is collapsed, and then we ventilate with high rates, flows, and then we give PEEP, and then we give tidal volumes, and all these things will contribute to the ventilator-induced lung injury. This Professor Gattattoni's baby lung concept, like we have discussed in the previous lectures. So when you are trying to ventilate, even with low tidal volumes, so sometimes you may cause overdistension, and then you may cause barotrauma and volutrauma. And then you have to understand this baby lung concept. You should not, like we used to think ARDS lung is a stiff lung. Now the concept of baby lung shows that it is a small lung, And if you understand this baby lung concept, then you can prevent, and then you understand stress and strain, you can prevent ventilator-induced lung injury. So the stress is nothing but the maximum pressure applied to the alveoli during the respiratory cycle. So what is this maximum pressure? This is the distending pressure of the lung, whether it is driving pressure or transpulmonary pressure. So the amount of pressure you require to distend the respiratory system, that is the stress. And strain is the amount of deformation or distortion or change in the shape of the alveoli from its resting state, from the FRC, that is the strain. So this is the volume, there is no unit for it, and then this is it is tidal volume divided by the functional residual capacity, that is the resting lung volume. And stress is a constant, that is elastic constants, and then that is specific for each species, and then you multiply with strain, you get the stress. So any stress more than the strain of more than 2 is harmful, and then the specific lung elastance constant is same for the human beings, it is 13 centimeters. So do you think the plateau pressure is a good measure of stress? So we use plateau pressure, and then we think that is that we can surrogate for the and then if you maintain the plateau pressure of 30 centimeters of water, we think we are limiting the ventilator-induced lung injury. So, but if you see this model, and then if the patient is breathing spontaneously, and then if you see the pleural pressure, negative pressure, and the plateau pressure of 30 centimeters of water, and then if you look at the transpulmonary pressure, it is 45 centimeters, where you are giving more stress to the respiratory system, and then at the same time, if you give neuromuscular blockers, or if the patient has any pleural effusion, and the pleural pressure becomes positive, then you are giving less strain to the alveoli. So not the plateau pressure, and if you can monitor the transpulmonary pressure, that is better surrogate than your plateau pressure. But you need to measure the esophageal pressures if you have a esophageal balloon, and then if you measure esophageal pressures, so we can extrapolate that, and then we can get the transpulmonary pressures. So we traditionally select our tidal volumes based on the ideal body weight. But is it the right approach to prevent stress and strain? If you see these two patients, like both are 70 kg patients, and then you selected 420 mil tidal volume, and then if you look at, as I told, the ARDS lung is heterogeneous, more heterogeneous, and then sometimes you give 426 ml per kg tidal volume. It is more for that particular patient, and then it causes more strain. So you need to know the functional lung size, and then if you adjust your tidal volumes according to the FRC, then you can reduce the strain, and then you can minimize the ergotrauma. So the strain on the lung higher if the tidal volume by the baby lung if it is higher. So then the concept of driving pressure came to monitor the compliance, and then to select not the tidal volume. So we tried to adjust the driving pressure to decrease the ergotrauma in these patients. But do you think the driving pressure monitoring is ideal to reduce stress and strain on the lung? So we look at this example. So we know the driving pressure is the change in volume to the compliance. If the driving pressure is more, the compliance is less. And if the driving pressure is less and the compliance is more, and then we get this by subtracting PEEP from the plateau pressure. And then this actually gives the alveolar distortion or deformation change. And Amato et al. So based on, these are the seminal studies in the ARDS, and then Amato et al. Like they have taken all these variables, and then he found the only variable which is improving the outcomes, clinical outcomes, that is the driving pressure. So from all these seminal studies, they concluded this driving pressure variable is a better surrogate to understand the strain on the lung. But is it true? So if you, again, you have to understand about the elastance of the respiratory system, and then you should know the total elastance, the both chest wall elastance and the lung elastance, and then again the transpulmonary pressure plays important role in understanding the elastance. And then if you see, If you see this pleural pressure and then the transpulmonary pressure, and then you will understand the lung strain better, and then how it is getting distributed when the chest wall is stiff and when the lungs are stiff. So concluding airway pressures, the goal of optimizing pressures is to minimize stress and strain, and then there is no single value of plateau pressure and PEEP is absolutely good or bad, and then it is driving pressure, transpulmonary pressure will get better information. And we know when the airway pressures are more, again, it causes disruption in the blood gas barrier, and then it causes as cytoskeleton fractures, and then it will lead to pulmonary edema. So the flow and respiratory rate also contributes to the ergotrauma, and the flow is nothing but strain rate and the tidal volume is nothing but strain amplitude, and then we have seen the driving pressure is the stress amplitude. And then from this Gattoni paper, from this equation, we can calculate mechanical power for a given patient. This is Accuracy's trial, and then when we use neuromuscular blockers, we have seen significant reduction in the mortality. This is again when you understand the transpulmonary pressures, and when you apply transpulmonary pressures, when you decrease stress and strain for a patient by using sedation and neuromuscular blockers, you can decrease the mechanical power, and then we can decrease ergotrauma. So this is again Gattoni's equation to calculate mechanical power for a patient who is on volume control ventilation. So data suggests when the mechanical power more than 17 joules per minute, then the mortality increases. So if you calculate mechanical power, and then if the mechanical power from here you can see it is 10 joules per minute, but actually calculating mechanical power and then ventilating patients based on the mechanical power, whether it will decrease mortality, it improves survival, still we don't know, but we can calculate the mechanical power by using these equations. And then this is a Becker's equation to calculate mechanical power when you are using pressure control ventilation. So this is one ventilator, it gives mechanical power. This is Mindray ventilator, and it automatically gives mechanical power on the ventilator. And then when they validated this tool, by using the equation by calculating mechanical power, it is they validated, and then it is around 95% sensitive. It gives the mechanical power directly on the ventilator. So to conclude, the concept of personalized ventilation for ARDS beyond lung protective ventilation, we are moving towards personalized ventilation. And we know ARDS is iatrogenic, like sometimes it is iatrogenic. We say ARDS is progressing, but not ARDS, it is progressing. It is the ventilator-induced lung injury which is causing the progress of ARDS. And now the concept of driving pressure and the mechanical power, these are the surrogates for ventilator-induced lung injury, and then we should move towards driving pressure and mechanical power targeted ventilation to get this personalized mechanical ventilation to prevent ergotrauma, to prevent ventilator-induced lung injury. Thank you.
Thank you, Dr. Subba Reddy, for that absolutely wonderful perspective on ventilator-induced lung injury. Moving ahead, we have Dr. Raghunath, who's consultant intensivist and HOD critical care at GGSM Hospital, Mysore, and he will be talking about converting NIV failure to success. Over to you, sir.
Thank you, chairpersons. So, when they gave me topic, converting NIV failure to success, when already there is NIV failure, failure means failure. So, next 12 minutes, I'm not pushing NIV when NIV fails. So, we have to go for intubation if the patient is candidate for intubation. But when the patient at risk for NIV failure, what to be done, that we can discuss. Keeping regular protocols, we can manage, but what extra we can do when there is patient is high risk for NIV failure, that we will discuss. So NIV has been expanded tremendously over the world in terms of spectrum of disease, location of its application, and achievable goals. NIV used to prevent acute respiratory failure, to prevent intubation as an alternative to intubations. So when we change the goals, our definition of success and failure also changes. So this is Copernican revolution because there is a significant shift towards greater use of NIV in place of invasive mechanical ventilation. Why we are using significantly? Because we are achieving same clinical outcomes as of invasive mechanical ventilation without complication related to intubation. So because of this, any patient coming to ICU with breathing difficulty, we are trying NIV and see what happens. So we will end up more and more NIV failure because if you are not following, if you are not selecting appropriate patient for NIV. So this NIV failure has been defined as need for endotracheal intubation or death. If you see in studies, it may occur 5 to 60% depending upon the location where you're using NIV, especially in ICU or ward or in emergency, or expertise involved in managing NIV. So this unsuccessful NIV associated with the independently death. So we cannot delay when there is NIV failure for intubation. The most important factor here is NIV failure associated with the cause of acute respiratory failure. Demul et al., it showed in 70 French ICU prospective survey, when you used NIV in de novo acute respiratory failure, or NIV use was 30%, with comparing to cardiogenic pulmonary edema and acute on chronic respiratory failure, he found that NIV failure is more common in de novo acute respiratory failure. Means if you don't know the diagnosis of acute respiratory failure before using NIV, you will fail more. So NIV failure is associated with mortality, and this unsuccessful NIV associated with death in de novo acute respiratory failure. Scala has shown very nicely, if the failure of NIV is strongly dependent on type of underlying disease. If you are selecting the golden clinical indication for NIV like acute exacerbation COPD, immunocompromised patients, acute cardiogenic pulmonary edema, in those patients, if you use NIV, success always follows. But if you use NIV in low risk, low chances of NIV success like asthma exacerbation, hypoxemic ARDS, then your chances of failure is high. These patients should be monitored in ICU and expertise should be involved to prevent NIV failure. These are the key measures to avoid NIV failure: timely identification of appropriate patient, early initiation of NIV and optimal settings, frequent reassessment of patient and attention to patient comfort, this is very important, adequate equipment, qualified respiratory therapist and respiratory therapist autonomy, patient education and multidisciplinary approach. These are the usual measures we follow in at bedside. And we can use so many scoring systems. This is updated HECAR score to know which is a patient is low or moderate or high or very high risk probability of NIV failure, so that we can select early and go for invasive mechanical ventilation to prevent mortality. So when there is a NIV failure, when there is an NIV process going on, with respect to timing of occurrence, we can divide NIV failure into immediate failure within 1 hour, which constitutes around 15%, early failure 1 to 48 hours, which around 68%, and late failure more than 48 hours, around 17%. So this immediate failure is due to clearing of secretion, hypercapnic encephalopathy syndrome, agitation and asynchrony. Early failure is most commonly due to poor blood gas exchange and increased severity. Late failure is related to sleep disturbance and severe comorbidities. So this is a very important slide. If there is a burden of secretion, we have an integrated strategy to reduce the non-invasive failure by using cough assist device like fiber optic bronchoscopy, high frequency chest wall oscillation, intrapulmonary ventilation. If there is a asynchrony, optimizing ventilation settings is very important. If there is a neurological dysfunction or intolerance, we can use safe sedation, safe analgesic sedation. And if there is severe hypercapnia, people are using ECOR, extracorporeal membrane carbon dioxide removal. And if there is severe hypoxemia along with NIV, there is option of HFNC. If there is lack of expertise, staff training is a most important criteria for the success of NIV. If there is a WILI, we have to avoid, we should go for protective lung ventilation, avoid tidal hyperinflation. If there is comorbidities, we have to take care of other organs also like heart and kidney. If there is immediate failure, NIV failure because of weak cough reflex, because of excessive secretion, especially of neuromuscular origin, acute respiratory failure with preserved bulbar function, we can use NIV with the early suctioning of secretion, as simple as that, or we can use minimally invasive or less invasive mechanical insufflation, exsufflation, high frequency chest wall oscillation, intrapulmonary percussive ventilation, early fiber optic bronchoscopy. There is no much strong evidence for use of these equipments, but this is a mechanical insufflation, exsufflation. It is more commonly used in neuromuscular disorder, but we can also use, they are also used in acute care settings. There is a protocol to use this insufflation, exsufflation that start in insufflation pressure IPAP plus 5 centimeter and exsufflation more of negative of IPAP. So there is few studies keeping pressure on plus 40 and minus 40, they found that the clearing secretion is better in these patients, but we need more evidence for this. High frequency chest wall oscillation and intrapulmonary ventilation. This intrapulmonary percussive ventilation is have more evidence, a non-invasive technique that delivers small bursts of high flow respiratory gas into the lungs and mobilize secretions. This is a randomized control trial, very small study, not a statistically not very significant. It is found that there is significant decrease in the respiratory rate, increase in PaO2 and decrease in PaCO2, and worsening of exacerbation was very less or nil in IPV group. So it found to be safe technique, but use in practically whether we can use or not, we need more studies on this. There is another RCT with small group 40 patient of COPD patient, NIV with the use of helmet. They found that duration of ventilator treatment ICU stay was reduced and improved gas exchange. It is found to be beneficial. We need more studies on IPV. This is a early fiber optic bronchoscopy during NIV by Scala et al. Is again small group 12-month prospective match case control study. 15 COPD patient with copy secretion found that improved gas exchange and improvement in the cough efficacy. NIV and avoided intubation in 80% of the patients. This is another indication, we actually hypercapnic encephalopathy and coma. Actually, it is a contraindication for NIV, but cautious application of NIV can be attempted in these patients by experienced team in highly monitored area with the backup rate or pressure control ventilation. There is a study for this actually 3-year prospective match case control study found that there is a days of ventilation was reduced significantly, and there is no difference in intubated and NIV patient with respect to long-term and short-term outcome. In fact, there is a reduced nosocomial infection rate in these patients. So there is another intolerance and psychomotor agitation. Again, if it is significant, we have to intubate and ventilate, but whether we can use of judicial sedation by expert team and highly monitored settings, can we avoid intubation? Yes, there is a safe analgesic sedation. There is a good number of studies using remifentanil, dextromethorphan for the poor NIV acceptance, and they found good outcome here. So remifentanil as well as dextromethorphan, because do not interfere with respiratory much, we can use as a mild analgesic sedation. This asynchronous is another important point here. Ventilator waveform, adjusting settings with the waveforms, adjusting trigger sensitivity, increasing PEEP, minimizing air leaks. Leaks are the important factor for the asynchrony. So use most appropriate patients, select flow trigger using time cycling, and people use even non-invasive NAVA for the improving synchrony. This is the interface rotation strategy. When there is you want to use for a prolonged session of NIV, we can interface rotation strategy using different types of oronasal, total face, nasal mask, helmets, and mouthpiece to avoid discomfort, because NIV discomfort has found to be 18% for NIV failure. So this, along with the hydrocolloids, foam, or transparent dressing, has a cushioning effect. Integrated strategy to improve blood gas during NIV, people have used HFNC as well as ECOR to improve blood gas. This is HFNC therapy in combination with the NIV in critical ill patient. Again, 532 critical ill patient, they found that ARF-related respiratory indicators are improved. Recent RCT have not shown much benefit, but this is one of the options. We need more studies when we want to use HFNC along with the NIV in these patients. ECOR is a partial extracorporeal support. Being a less invasive than ECMO, people are using this. This is one study, matched cohort with historical control, 25 COPD patient at risk of failure. They found that significant improvement in blood gas and intubation rate, but there is a risk of adverse events like cannulation problems, bleeding. These are major risks actually involved here. So these studies suggest not to use at bedside. Another ECLAIR study has shown the same thing. Intubation was avoided in 14 patients in ECAR group, but suffered major bleeding complication in this group. So there is no significant difference in length of stay or mortality rates. Still, I think it's experimental. If you use more and more, I think technology improves, we can use it later. Late NIV failure is another problem, 15% because of the sleep. So you have to take care of, make sure there is improvement in quality of sleep and frequent reassessment of the patient status. Once the patient improves, our monitoring frequency will be reduced. Make sure frequent reassessment is important. Hyperglycemia is a key. Here, correction of hyperglycemia, we can avoid late NIV failure. So conclusion, NIV should be considered as a rational art rather than advancement in technology. Again, basics, keep basic right, timely identification of the appropriate patient. Expert team and highly monitored settings are required to manage patient at risk of NIV failure. Avoid delayed intubation if NIV fails. Thank you.
Thank you, Dr. Raghunath, for that excellent talk. Now the forum is open for questions. I request the speakers to come to the stage. Because the time is limited to 5 minutes for the discussion, can we limit the questions to 1 or 2 max, please? And 1 question per person.
Check. Good morning, all. All the sessions were very nice, sir. So I have a question to Dr. Suresh, sir. So he said about permissive atelectasis. So in which subset of patients can we choose, like lung rest or permissive atelectasis? Like, is it only for ECMO patients, or how do we choose, sir?
The whole idea of that talk was not to show you the slide. Because obviously the idea was to float the idea and not to get any questions on that topic, because then that opens a Pandora's box. Yes, permissive, we and Dr. Ram were discussing the Habermas's hypothesis of this whole concept of keeping the closing, and is this whole thing not a right thing to do of trying to open the lung, is based on the fact that what is actually occupying the lung is not atelectasis, but is actually fluid in there, and at that particular point in time not to move that may not be a very good idea. How to select patient for permissive atelectasis? So I would say that if you are trying to open the lung and your driving pressures are too high and you are on 4 ml per kilogram, the moment you try 6 ml per kilogram or 4 ml per kilogram, and you're not even with a 10 PEEP, your driving pressures are very high, just forget about it. So then at that situation, if you don't have ECMO facility, or if you don't have any alternative facility, you've prone the patient, that's the best recruitment, then sit tight, then you can use this hypothesis. Otherwise, probably no. So the whole idea was not to ask that question on the whole.
Thank you, sir.
You opened up the debate, so it's going to.
If there's time, can I have one more question to Dr. Ghanshyam, sir?
If there's nobody else for questions, then I'll give it to you.
No, I'm not going to ask question. One thing was there in slide of the Dr. Subba Reddy. He is very favorite person for me. So the thing is that one you showed in slide that published in Journal of Critical Care Medicine. So in that graph they used first, you will see that slide, sir. First, it showed they used Pearman correlation coefficient, and second they used the Blandmann-Altman analysis. So in that second Blandmann-Altman analysis, I request you that I don't know what paper you have taken that, but if you will look at that, their statistical analysis, it is not showing clearly as it was showing in that Pearman correlation coefficient. So you please send me.
That is the mechanical power, the last slide, I think. No? So
Yeah.
Calculating the mechanical power, validating mechanical power study.
Yes.
Yeah.
One, and second thing for Raghunath sir. So did you find any study during COVID time that NIV failure to success?
See, NIV failure, as I mentioned in
During
first
COVID,
slide.
I'm asking.
COVID?
Yes.
NIV failure to success.
Yeah.
I'm
Because
not-
I would like to know the sensitivity and specificity of that particular
Same,
thing.
there is, I don't think
There
there
is only one study of HFNC published in Journal of Critical Care Medicine. So we got at that time how we will proceed for the success rate. And that is my paper, ROX index. So only one study, because I was searching that during you were delivering your lecture, so there was no any study. That's why I'm asking you. Thank you, sir.
Thank you. Do you want to take the last question? There's nobody else for the question. We'll take the last. Yeah, please.
Ram Sabiko, I have a question to Dr. Ganesham. Just what is the role of respiratory drive with that of misnomer of happy hypoxia in COVID? So what is relation between these two?
So I think, see, basically the happy hypoxia concept, see, it all depends upon whether your respiratory center is stimulated adequately or not. Probably in some of the patients with COVID, where there was hypoxia, but the respiratory center was not adequately stimulated, I think those were the patients who did not manifest a high respiratory drive and did not have the associated respiratory stresses that we would normally see in patients who are hypoxic. I don't know the exact reason or mechanism why these patients would have did not manifest that, but maybe if you look at the various stimulants for the respiratory center, like your PaCO2 or a PaO2 or the abnormal stretch receptors from the lungs and the thorax, which usually get